Welcome to the Nursing Post podcast, all nursing all the time with Ashley Moore and Rosa Horsley. This episode is about Alzheimer's, and even though a lot of awareness has been brought to the forefront, there is still a lot to learn. And our goal is always to inform, help, and start conversation.
It's been said by many of people that Alzheimer's is harder on the family than it is on the patient. And as nurses, we feel that that's probably pretty fair, but there is a little bit that's missing from that picture. We feel that in the beginning, it's probably more difficult on the patient, but as the disease progresses, that's when it becomes harder on the loved ones and caregivers.
Absolutely.
Because patients do realize in the beginning stages Something's not right, that they're forgetful, and that is a hard diagnosis.
So what is Alzheimer's? It's a type of dementia, and according to the CDC, it's a progressive disease beginning with a mild memory loss, possibly leading to loss of the ability to carry a conversation and respond to your environment. So that involves the part of the brain that controls your thought, your memory, and your language. And it can seriously affect a person's ability to carry out ADLs.
Yeah.
So the cause of Alzheimer's is still unknown. Even though more and more people are being diagnosed, we still don't know what's causing it.
Right. And, of course, my little part that I love so much is
numbers.
The numbers.
The numbers.
Alzheimer's is the 6th leading cause of death in the United States. And it's estimated that 5.8 million Americans age 65 and older are living with Alzheimer's dementia this year, and 80% are age 75 and older. So it's really a disease that
it progresses.
It's a progressive disease. Almost 2/3 of Americans with Alzheimer's are women, and older African Americans are about twice as likely to have Alzheimer's or other dementias versus their white peers. And Hispanics are about 1.5 times likely to have Alzheimer's or other forms of dementia compared to their white peers. Between 2000 and 2018, the number of deaths recorded more than doubled. It increased 146%, and that's off of death certificates. And the number of deaths associated with heart disease actually decreased.
It's ranking up there with one of the leading causes of death.
Right. So we're getting better with heart disease, and that's came down 7.8%, but a huge jump with Alzheimer's. And lastly, which is a huge impact on our healthcare system.
Absolutely.
In 2020, Alzheimer's and other dementias will cost the nation $305 billion.
Yeah, and by 2050, it can be as high to $1.1 trillion. That's a lot.
Well, and that's for one disease process.
That's a lot. And they do need care throughout the different stages of progression, so... And it's not cheap.
As it progresses, the care that they need intensifies, and it needs to be more one-on-one almost, especially if you have somebody that's really in a bad way where they have no control. They can't feed themselves, they can't toilet, they can't do any of those things.
So there are 3 stages of Alzheimer's: mild, moderate, and severe. Those with mild Alzheimer's, they can pretty much function independently. The issues that they usually have are problems with words and coming up with the right word or name during conversation, remembering the name of new people that they're introduced to.
Right, so short-term memory.
Absolutely. If I just introduce them to you and then 30 minutes later, honestly, they're not going to remember who you are. They have difficulty performing tasks in social and work settings. They forget material that they just read. They lose or misplace valuable objects. And they experienced increased trouble with planning and organizing. They're usually unable to retrace their steps. So if I lose my keys, I'm able to say, okay, this is the last time I had them, and then I can track my movements from there. But they can't even tell you where to start.
Right. So most of these are affecting short-term memory, being able to, I need to do these 3 things. And that's where the organization and planning and being able to follow through just lacks a little bit. So there is a moderate stage where they have a little bit where it's more of an issue with completing daily tasks. So this is the longest stage that most people live within. with Alzheimer's. A lot of them need assistance with their ADLs. You'll have to go with them to doctor's appointments because they're forgetful with their personal history, or they don't remember certain events that have happened in their life.
Mm-hmm.
There's trouble with feeling withdrawn. They have trouble with social or mental situations. They can really get kind of agitated and moody because of that. They're unable to call things like their phone numbers. They are things that they've known probably for years, maybe in a distant past. Their high school they went to.
Their social security number is a big one.
Right, their social security number. They can't remember those things. They don't look at them all the time, or they don't have to recall on that memory a lot, so kind of fades. There is trouble with confusion. They don't know what day it is, what time or place, maybe inappropriate clothing.
Yes.
It's the middle of December and they're in shorts and tank top.
Yep.
They can get to a point having trouble with their bladder or bowels. So
they become incontinent. Mm-hmm. They experience changes in their sleep patterns. Maybe they are now night owls when they've never been night owls before. Mm-hmm. They're up all night and sleeping all day. And then, they're showing an increased tendency to wander and become lost. So that trip that was probably meant to go to the mailbox and grab some mail has accidentally now become a walk around the neighborhood, and they can't find their house. They demonstrate personality and behavioral changes. They tend to become a little more suspicious, delusional, compulsive, or they, have repetitive behaviors like hand-wringing and tissue shredding, vision problems, difficulty with balance, difficulty with reading, judging distance, determining color and contrast. So when I worked in the dementia unit, there were things that we really tried to avoid. Those black and white tile squares that were so popular way back in the day, that's definitely not a good idea with someone who has dementia because, one, they have issues with distance, and then they have an issue with contrast, so that those black squares might actually, to them, look like black holes, and if they step in them, they have this fear that they might fall.
Right.
So
that perception's a little bit off.
Perception is way off, yeah.
And I would say that this stage, when I had worked in long-term care and skilled care, this is where we got a lot of our patients. They were in this moderate stage. And I think that people had tried, their family had tried to keep them at home as long as they could, but then they just weren't able to keep up with, I need to sleep, and I can't sleep because they're up all night, but then I have to work the next day, and I need to find coverage, and it just gets to be too much.
It does, because now they're maybe displaying some behaviors that they didn't display. Maybe somebody who was very mild and meek-mannered when, they were younger is now, just a little mean and short.
A little feisty.
Yes, a little spunky. And, on top of that, you're having to deal with them wandering out into the street. So it becomes, a safety issue.
It really does. So the next stage, of course, is severe. And this is just where individuals lose their ability to respond to their environment.
Yeah, it's extensive care at this point.
I mean, they're just not... They're not checked in, as I would call it.
Yeah, they're not aware of their surroundings. Somebody's having to give them complete and total care. Mm-hmm. They're absolutely incontinent. They are having issues, eating and swallowing. They can't communicate. And because they're not very mobile and active, they're more prone to having, pneumonia and infections set in. So at this point, as the disease continues to progress, palliative care and sometimes hospice is called in to just kind of make their transition a little easier.
Right. When you go to assess these patients, it's just a very flat effect. There's just nothing really responsive at all. It's very, very sad. There are some treatments for Alzheimer's. Mm-hmm. There is not a cure. And looking into the research, there's not really been a lot of changes that I've found. There's a lot of research going on now, but not a lot of changes. So one of the problems with the clinical trials is it does great in phase 2. And phase 2 is it was experimented on a rat or something like that.
Oh, man.
And when it tries to go to phase 3 to human trials, it fails. And all these failed trials over and over and over again.
That's expensive at this point, because I know we've been nurses for over 10 years now.
Yeah.
And these are some of the same medications from day one. The only difference is now they're available in generic form.
Right, which makes them a little bit cheaper. But one of the things, because one of the questions I have is, well, why are these clinical trials failing? Because that's the kind of person I am. Why?
Why? What's wrong? Yeah.
And what the scientists have almost kind of agreed on was that by the time patients are brought in and started in these trials, they're too far gone. Their cognitive state is just past what these medicines are going to be proposed to be used for. So that's kind of the thought process. Yeah. So what you would need to do is when you're screening and there's mild cognitive impairment, not necessarily Alzheimer's or dementia, which a little cognitive impairment, which a lot of elderly have. They're still functional. They're still safe.
Yeah, they can still drive. They can still cook. They can still
But that's where you start introducing these medications, because we know that there is a link between the mild cognitive impairment and the Alzheimer's disease.
Yeah.
So the early diagnosis and getting people to understand that they have a mild cognitive impairment and now is the time to start on therapy.
It's hard.
That's a whole other subject.
Yeah, that's hard. So some of the medications for Alzheimer's disease are cholinesterase inhibitors, and they're prescribed generally for mild to moderate disease. And these drugs help reduce some of the symptoms and control some of the behavior symptoms. The medications, I think the one that I'm most common with is Aricept.
Yes.
That's the one that I see that's prescribed a lot. There are a couple of others, but now that that's gone, to generic form, I see that a lot in patients.
Right. I would agree with that. What's really interesting is we really don't know how these medications work.
It's pretty scary, but okay.
So what we think happens is they prevent the breakdown of acetylcholine, and that is a chemical found in the brain that we think is important to memory and thinking skills. And as Alzheimer's progresses, the brain produces less and less acetylcholine, so therefore these medicines inhibit that loss, so they keep that chemical that is needed.
Mm-hmm.
That's the thought.
So, yeah, it doesn't cure anything. It doesn't take time back, but it kind of just slows the progression of it down.
Correct.
So instead of seeing somebody... this is probably why there's a lot longer, stage in the moderate, because, they're medicated and it's slowing the progression down and slowing it down. Just my food for thought. So when we start going into the moderate to severe disease, we're still talking about oral medications. The most common one in this stage is Namenda. And it's an antagonist. It's an N-methyl D aspartate antagonist, and that's a mouthful.
It is.
It's prescribed to treat moderate to severe Alzheimer's disease, and this drug's main effect is to decrease symptoms, which could allow some people to maintain certain daily functions a little longer than they would without this medication. And generally in nursing, we see Aricept and Namenda both prescribed at the same time.
Yes, and
so it's not abnormal. And I think here recently, I can't remember the name of it, they've actually combined these two medications into a pill.
They have.
One pill.
Yes, they have.
So, that's a little progress.
Mm-hmm. Oh, absolutely. And the way they think that Namenda works, these NMDA, which is a lot easier to say, antagonist, the way that we think that they work is we're trying to regulate glutamate, which is another chemical found in the brain. And when produced in excessive amounts, the glutamate leads to brain death. So we're trying to stop that chemical.
So there are other therapies that can be used besides oral for the treatment of Alzheimer's, and some of them are actually behavioral. And I know we've touched on some behavioral therapies in our earlier podcast episodes when we were talking about autism, and I found it kind of interesting that some of those same therapies are used here, so that's kind of exciting.
And I read a little bit about this, because then I kind of went down my little rabbit hole when I was reading this. And I was like, this is just so interesting. They're using the same therapy. But let's think about it though. If you have a person who is autistic and they have a hard time understanding speech and thought process and socially acceptable skills, well, Alzheimer's have the same problem. I mean,
absolutely.
They'll be digging in the britches in the middle of the hallway.
Oh, they will.
And that's not socially acceptable.
It's kind of interesting because until I saw the outline for this, I would have, I don't know, I just would have never thought.
Yeah.
You know?
And I was like, well, that makes sense. You need to work on those social skills. And one of the things that the thought process is, patients who have Alzheimer's, they can't articulate their problem. Mm-hmm. So trying to talk to them in a different type of way makes them respond better. Mm-hmm. We all are like that.
Absolutely.
I mean, if you come to me and I'm like, hey, I need your help. Can you do XYZ? Sure. But if you come up to me and you're like, you need to get over there and you need to do this, I'm like, yeah, I'm busy.
I also learned working in the dementia unit to never ask questions that can always result in the answer no, because apparently they love to answer no. So instead of saying, would you like a shower today? Their answer is always going to be no. So I had to sit there and think, okay, I've got to get this, patient in the shower another way. So I'd be like, let's go take a shower now. We haven't had a shower in about a day or two, so let's go on to the shower and get clean and all that good stuff. And they were more apt to go with me saying, hey, let's go ahead and do this instead of, would you like a shower today?
Right, because they will refuse and refuse,
everything.
And then you have to say, oh, well, they have the right to refuse. They're not really in their right mind, and if they were, they wouldn't refuse a shower for weeks on end.
Absolutely. So you just have to approach, it's everything in life is approach. So as Alzheimer caregivers know, the disease is more than just losing your memory. Sometimes aggressive behaviors, agitation, and anxiety, develop, and these are symptoms that are commonly treated with antipsychotic drugs.
Yep.
But according to a recent report from the Government Accountability Office, 33% of people with Alzheimer's in nursing homes are prescribed antipsychotic medications. Understanding that medication can be necessary for emergency situations, a recent study found that antipsychotics were about half as effective as behavioral therapy. And that their use can have some deadly side effects. I mean, some of these medications have black box warnings on them.
They do, and the FDA has issued warnings that using these medication increases mortality. In the
elderly and the demented population.
Right.
I mean, absolutely. Everything has side effects, but towards this particular demographic of patients, it's that benefit outweighs the risk type of thing. And being nurses, working long-term in SNF and ALF, we're always taught to take the least restrictive or restraintive approach because restraints in some situations are illegal. And if they're not documented and care planned correctly, like you could be legally, holding somebody, captive. I mean, let's be honest, and an antipsychotic, it kind of does that. So
it really does. And it was kind of sad to think that these medicines increase mortality in patients with dementia. We're giving them anyways, but you can use ABA or CBT therapy and get better outcome. Mm-hmm. Why are we not doing that? We need to train for that. Like the people who are working these long-term care, SNF, assisted living, they should be trained in these approaches.
Absolutely.
For patients. And I know when I was there, I wasn't trained in any of these.
Well, in ALF, I think you're only mandated to take like a 4-hour class, like 4 hours of training a year. And sometimes it's the same training, so you're not really getting
new up-to-date information. Watch this video for the 4th time.
Yes, absolutely.
So the use of the CBT therapy or it's cognitive behavioral therapy, it has been studied and it is a great treatment option for Alzheimer's patients because it helps them understand the missing link between the patient's actions and their feelings and their thoughts. So why the patient is behaving that way. And then using that knowledge to make a positive change, which is fantastic. It's going to just take a little time because you'll have to actually talk with the patient, kind of figure that out.
Spend some time with them.
But over time, it will help people cope with mental health issues like anxiety and depression, not just dementia, Alzheimer's, or even autism.
Yeah.
Like, this is across the board a great approach to talk to people and understand what's going on. Finding the missing link to the behavior versus what is expected, fixing that, and then the behavior goes away.
Well, think about it. Let's say you're a nurse and you have to shower a patient, right?
Mm-hmm.
And instead of going in there and introducing yourself, chatting, it doesn't even have to be a long conversation. Now you've built rapport with the patient, right?
Mm-hmm.
So imagine I didn't do that. These people generally can't even remember new faces day to day. And here I am, the stranger, and I'm just like, come on, we're going to go take a shower. You're wondering why she's or he is scratching and biting and hitting you. Like, you're a total stranger to this person.
Yes. I had a patient one time that had dementia, and she hated showers. They're
like cats.
Showers. I mean, it was awful. She would cry. She would fight. And then she would just cry. It was horrific. And I never understood why she behaved this way. And her family came every week to spend time with her. And one time I called her daughter and I said, bath time is a struggle. Like, for real. And she's like, really? Mom loves baths. And, I think bath, I don't really differentiate between bath and shower. You're cleaning yourself, whatever you want to call it. And I said, yeah, but every time we go to the shower room, it's an issue. And I called it a shower room because that's the name that was on the door.
Absolutely.
And the daughter paused and she says, are you giving her a bath or a shower? And I said, well, the shower. I mean, really, let's be honest. It's a lot easier than filling up the big jacuzzi tub. Absolutely. It's a whole other process. So, and we're getting clean. We're washing it down. You're bathing. I don't really care which one you take.
A lot of places don't even offer shower.
Well, I found out that from talking to the daughter, she was a prisoner of war, thrown in a camp, hosed down, sexually assaulted. No wonder she doesn't like showers. No wonder she doesn't like showers.
Sometimes it only takes a 5-minute conversation.
And so I would go see her and say, it's time for your bath. And then we would go to the bathroom where we'd fill up the tub and she would just soak. And I would sit in there and chart. Because you can't leave her by herself because she's demented. Yeah. I don't think she could crawl out of the tub, but we're not really taking that chance on my wash. Never an issue again.
Wow.
Never an issue. But you don't know it until you have a conversation with somebody. And she couldn't tell me that. I mean, there was no way for her to articulate that. But yeah, sure enough, we'd have twice a week. Man,
the best time.
I'd get caught up on my charting and she'd be doing the bath and we're good to go. And the CNAs love me because they didn't have to worry about that patient in the bathtub.
Sometimes it's just a conversation. Just ask questions.
Yeah.
Let's talk about the use of herbal therapy. I know there's quite a few vitamins or multivitamins.
And I was kind of surprised to see that these are being studied as much as they are. Just because
they're not FDA regulated.
Well, they're not FDA regulated. And come on. I've worked with a bunch of docs, and you start throwing around herbal supplements and things like that. They're like, poof, there's no studies and da-da-da-da, and it's just this whole gamut. But for this, there's actually published literature that some of these herbal supplements are helpful. One of them, ginkgo biloba. There was 4 well-designed, randomized, placebo-controlled trials that met inclusion criteria. So this was set up like a drug study,
there's a controlled group and there's a non-controlled group.
And what they found was that this ginkgo biloba extract, 120 to 240 milligrams a day for 3 to 6 months, had a small but significant effect on objective measures of cognitive function. If you're taking this ginkgo biloba in addition to the medications that are out there, that's when you start compounding some of these things and
that's
getting a good effect, in my opinion. Because I'm like, this is an extract, this is an herbal supplement. You can take this with this other medication and let them work together.
And so lower dose vitamin E is recommended by many experts for patients with Alzheimer's, and it may be associated with lower risk of adverse effect without compromising any of the beneficial effects. They're thinking 400 international units twice a day.
And that's a standard dose that you can find over the counter.
Yeah. So
there is another medication that you can take if you can't tolerate vitamin E, but that's really not recommended unless you have like serious GI side effect from taking vitamin E. And I'm going to try to pronounce this. I think it's Selagiline.
Looks correct to me. I feel like they purposely do this. They purposely make up these difficult to pronounce names so that they can laugh at us when we try to pronounce them.
That's okay.
And then the name brand everybody can say. It's like so somebody's going to laugh at us.
That's okay. They're going to say they butchered that terrible.
It's okay. Because the option for a one-size-fits-all type of cure seems like a fairy tale. Just like pronouncing generic drug names. It sounds like a fairy tale.
Yeah, that's a good way to put it.
But science is improving, and it will, have a very different patient-focused approach for treatment.
Yes, because they can't find one link and one reason. We don't know what the cause is.
Yeah.
So because of that, if you don't know what causes it, it's harder to fix it. So now they're just trying to work with some of the things that they're finding out with the research. By 2050, 14 million people will be diagnosed with Alzheimer's. That's
a lot, man.
That's a lot of patients. And with no known cause or cure, healthcare providers will need to be able to provide education, empathy, compassion for patients and their families because it affects their families.
Absolutely.
And educating ourselves on alternative ways to manage these patients seems like it would go a long way.
Absolutely. Beneficial for the patient and for the family. Trying to think out of the box, So we want to thank you for listening to this episode from the Nursing Post. And of course, we will link our references to our website, www.thenursingpostpodcast.com. And be sure to check us out next week when we discuss current Alzheimer's research, along with tips for caregiver stress and resident placement.
Thanks.